As a surgeon, Keynote 522 study demonstrated that TNBC patients could benefit from neoadjuvant immunotherapy despite PD-L1 expression level by conventional staining. So in your opinion, what are the potential role of immunotherapy in the neoadjuvant and adjuvant setting of breast cancer treatment? And also, is there a role for immunotherapy in cancers that are typically immune cold, such as hormone-positive breast cancer?
Okay, this is an important question. Keynote 522, we're all very excited about that clinical trial, because that one with neoadjuvant chemotherapy combined with pembro, if I remember, anti-PD-1 pembro anti-therapy. And that result came out is chemotherapy alone is 51%, and then with the pembro it's 65%. It improved the 10% response rate. That's very, very, very encouraging. And that's where the anti-therapy, the immune checkpoint therapy come in. So now, let's question 65% versus 51%. It's a 14% increase. We should all very pleased, but I'm not a physician, okay? I don't see patient by myself. You guys see patients, so you are more realistic. I'm not realistic. I'm thinking. I'm non-realistic. Why only 65%? Why not 100%? What's wrong to be 100%? Well, I know you guys seeing the patient, you say, oh, come on, give me a break. 100% is impossible. Everything is from impossible to become possible. And so as a scientist in the lab, that's what we daydream. We dream something impossible. Why not 100%? Okay, now come back to your the question you asked. Why only 65%? Is it possible among those patients that it was selected to be treated with by this neoadjuvant therapy combined with pembro? Did they select the PD-L1 expression? They didn't. In the trial, they just did it. And or even they did it, that they may not use the right antibody. I don't think they did it. So let's say the one I just mentioned, that glycolysis method, the antibody is there. If we combine that method into this trial and to select the right patient, those patients who are PD-L1 positive, the real positive, not false negative. And then in the trial, is it possible this 65% become, I don't know, 75%, 85%? I think it is possible, because just logically, that's the way it is. Why only 65%? The other 35%, many of them are likely PD-L1 expressed. So use a pembro. What's that for? Nothing is going to happen. That's why they are not improving. But if you say, okay, this patient PD-L1 negative, let's remove it away. So in a way, we reduce hormone, right? We increase Hunzi. Then that's situation potentially higher. So in this way, this is so-called the precision medicine concept. So I think that is possible. And if we use that method to apply